Hello everyone, my name is Mary Samuel. I work in the National Health and Social Care Professions Office. It's my pleasure to welcome you to the third session of this webinar series hosted by the National HSCP Office in collaboration with the Institute of Leadership, RCSI. The theme for the series is HSCP Leadership in Practice during COVID-19. In today's session, we are delighted to showcase exemplary clinical leadership demonstrated by some of our HSCP colleagues who work in older persons, disabilities, and psychological services. Our distinguished guests in today's panel are Ms. Jackie Reid, Dr. Sharon Kennelly, Ms. Adeline Quinn, and Dr. Damian Lowery. Ms. Jackie Reid is the national lead of the National HSCP office. She's kindly agreed to facilitate the panel discussion. Thank you, Jackie. Sharon is a clinical specialist dietitian working in CHO8. She provides a clinical dietetic service across residential care sites for older persons in 4 Midland counties. She's the dietitian representative on the HSCP working group of the NCPOP. Since May 2020, Sharon has been seconded to HSC National Primary Care Strategy and Planning Office, providing support to national nutrition initiatives and policy development. Ms. Adeline Quinn is a speech and language therapist. She has provided speech and language therapy to children and adults who have speech, language, and communication needs and eating, drinking, and swallowing difficulties. Adeline is currently working as SLT manager in a multidisciplinary clinical team in Stewarts Care in Dublin. Dr. Damian Lowery is a chartered senior counseling psychologist in Mater University Hospital. He works with patients across multiple departments who have varying psychological needs. Areas of particular interest for Damian are pain management programs and supported self-management programs for those with a diagnosis of any chronic condition. Damian also offers stress control lecture series and is involved in research. Thank you, panel, for joining us today. Without further ado, I'm now handing over the session to Jackie.
Thank you very much, Mary. I'm delighted to be here today to facilitate this conversation with our panelists and very much looking forward to the discussion. I'm going to come to you first, Sharon, if I may. I know you're a clinical specialist dietitian in CHO8 and will have been involved with residential care and a lot of other important areas during this pandemic. Could I ask you, Sharon, to take us back to the beginning of the pandemic in March of this year and tell us a little bit about what work was like for you and what changed and what had to change in the health services as a result of COVID-19?
Hi, Jackie. Yeah, so as we know, back in March, it was a time of huge challenges and a lot of change that had to happen very quickly. And so in March, 16th of March, I got a call to go in to train to work in testing and swabbing in the sites in the community setting. And at that time, I would have been working as a clinical specialist for older persons across 4 counties, providing a clinical dietetic service to 9 sites, about 400 beds. And I suppose the 17th of March, I was redeployed immediately to the testing sites. And I suppose because we had a substantial service to the sites over the last 10 years, and with my predecessors, we had built up multidisciplinary nutrition teams, we had policies in place. So I was able to pull together very quickly a contingency plan for our sites to guide our nursing colleagues when we wouldn't be on site ourselves. And I was providing an over-the-phone service to the sites as well in between the days, not working in the testing sites, because they were receiving, say, a lot of discharges from acute settings and also people on enteral tube feeding and similar. So I suppose with the redeployment, we were well, I suppose, we were well prepared in a way with all of our policies and things in place, but I was I was very conscious that other areas wouldn't have had the same level of dietetic service, wouldn't have had a clinical specialist post in place, wouldn't have any access. And I was very, very conscious that people would be maybe in worse circumstances than ourselves. And speaking to colleagues, you know, we all were concerned that while nutrition might not be the top priority, to be seen to be top priority in the immediate term, we knew that this area definitely, that we had expertise, that we could help, and that we could put together something that might support people on the ground. I suppose what changed for me as well, unfortunately, about a month later, the beginning of April, I contracted COVID-19 myself, and I suppose I became very kind of acutely aware of the side effects of the disease and how it affects nutritional status. And I suppose I had the kind of classic COVID myself, high temperatures, cough, loss of appetite, complete loss of taste and smell for 6 weeks. I was very lucky, like, to only have mild or moderate disease. And my husband subsequently as well was COVID positive. But I suppose I was thinking to myself, how would an older person cope with this? How would someone with dementia, communicate their loss of taste and smell? You know, if I lose 5 or 6 pounds, you know, it's not going to have a long-term effect. But for somebody that's on the edge of, you know, developing a pressure sore, or is already frail, this is going to have a huge effect for their care. And so I suppose all those things kind of came together at the one time at the start of when we developed this resource.
Thank you, Sharon, for sharing that. So clearly you are driven both by your professional expertise and knowledge, and very much informed by your personal experience, and I'm glad that you're all doing well after that. Could you tell us a little bit then about a bit more about what the thinking was behind the initiative, and, you know, why you felt it was so important, and the kind of resource that you and your colleagues were able to put together?
Yeah, thanks, Jackie. So I suppose what we felt that we were coming back and we were looking at these webinars at night time, and all the papers and evidence that was coming through, as I'm sure other colleagues would have been, from China, Italy, Spain, and really shown the really negative effects that COVID was having, particularly in the older persons, particularly in residential care settings. And we felt it was really important that we try and recommend a very proactive nutritional approach, and I suppose a treat without delay type of approach, because there's really just a very small window before somebody's nutritional decline will translate into increased frailty, increased risk of falls, increased development of pressure ulcers. So what we wanted to do was put together something that would you know, reflect a kind of an active treatment plan, but that would be relatively simple for staff to implement without needing further support. So we came up with kind of 5 key actions that nursing colleagues could take without kind of needing you know, any further clinical decision making, and also kind of an algorithm of care that they could follow. And I suppose it's not normal routine care, so not to replace the normal procedures and policies that they have in place, or that this could replace the expertise that they needed from other healthcare professionals, but just something to tide them through, I suppose, as it was being called at the time, the war times, something to guide their practice. We were conscious that there would be a lot of staff maybe coming into residential care settings to work who maybe never worked there before, and they wouldn't have time to take out books of 30 or 40 pages of policies. They need something, you know, literally in 8 to 10 pages, the most important key points that you need to know to support these residents during these times, to make sure that they don't have nutritional decline. So I suppose our thinking behind the pack is that we would have to cover something in terms of a very brief care algorithm that could be literally stuck on the wall, a one-pager. We would have one menu, a snack list, we would have drinks options. We would have advice around things like refeeding syndrome, which is, you know, it's an unusual risk, but it could happen in this time. Advice around palliative care, and particularly at the time, which was a huge area of interest in the media and in healthcare, vitamin D. So just to make a simple recommendation to the sites around those things. So we pulled together the resource over 2 weeks. and it was very much like kind of get the dream team together. So I suppose, you know, we knew that there's only a small number of people that we could pull together as people were redeployed, but say we had Margaret O'Neill, the national dietitian lead, and the chair of the older persons interest group of the INDI, which is the professional body. We had Anne-Marie Bennett, who had won the Excellence Award for the HSE for catering projects in St Mary's, and they had a huge amount of resources that were ready to go there, and we could share those. So, you know, we also, you know, pull together things that were already existing, you know, and that could be shared with others in the format of this pack.
Thanks, Sharon. That sounds like a phenomenal piece of work and an incredibly important piece of work that you pulled together in a short period of time. And clearly that, as you described, the dream team that you had together, and maybe you could tell us a little bit about what happened after you developed the resource.
Well, I suppose one of the key enablers is that I suppose I would have built up a network of people that I would communicate with, and then all those people who got involved, they brought their networks on board. So I suppose, like if you take obviously Margaret O'Neill as the National Dietetic Lead, she was able to directly communicate with Siobhan Kennelly, the National Clinical Lead for Older Persons, David Hanlon, the National GP Clinical Lead, and she said, look, we can get a working group together, we can do this for you in the next 2 weeks. And they said, yeah, look, we're hearing this back from the ground. Staff are concerned about this. It's coming back from the nursing homes as an area of concern, nutritional care. Please, can you do something? And then Deirdre Lang, the nursing clinical lead, she had set up a network with all the directors of nursing and a WhatsApp group across, I think, 400 or 500 people. So that was a direct link out to all of those people. To our professional body, we would have links with the Food Safety Authority of Ireland, so we linked with them immediately to get the correct vitamin D information to be able to disseminate that out very quickly. I had been working with developing an education program for GPs, so I went to ICGP, and it turns out they have an older persons interest group led by Dr Lucinda Dockery, and she was very helpful. Everybody was very supportive and willing to kind of disseminate out information that from a trusted source to their network. So that was a huge enabler for it. The second piece, I suppose, was that we already had a kind of a digital hub for resources in place. So it was something that we developed under primary care a couple of years ago, www.nutrition supports. And that meant that we had already worked with HSC Communications before, and Sandra Hogan from HSC Communications came on board, and she helped us to kind of design, I suppose, a better looking resource that would be easy to read and user friendly, and she put it up on the web pages for us as well. So having that kind of a digital place where everybody could be just sent a link to it, so that that would help to disseminate the work as well. And as I say, like, all the clinical leads were really accessible during that time, and really interested to hear everybody's ideas, and what if anyone thought they had anything that could help, they were open and willing to listen to that, and that was really, really helpful as well.
Thanks, Sharon. And how did you get your final product out into the system, into people's hands?
As I say, we used networks that I suppose everybody had. So I suppose once the clinical leads endorse it, so it literally, as I say, after 2 weeks it was done and it went up for a clinical sign off, then they were able to put that out to the doctors, to the nurses via their networks. And we were also able to do a webinar via the All Ireland Palliative Care group, and they facilitated that, and we were able to put the webinar up then, and they hosted it on their website, and a lot of nursing directors of nursing in the nursing homes were tuning into that at that time. We were able to send it out via, as I say, the normal HSC communication channels, and we had our, as I say, our professional body networks, and then the local networks within the HSC for community dietitians and residential care sites. It went out to the heads of service and down through their channels as well, and heads of discipline. So it did reach the ground, and when I saw people starting to tweet sections of it saying, "This is helpful, look at this," I said, that has worked then, if even a couple of people found it helpful,
That sounds excellent, Sharon. And finally, maybe just at this stage now, reflecting back on that, what would you say was your key learning from all of that work?
I think reflecting back on it, I think at the very beginning, it was very it was demoralizing to feel that maybe you wanted to help, but you thought you were going to help within your professional expertise, but actually, you know, being redeployed, that was a completely different experience. But still, you know, we knew that we had knowledge and experience, and we knew we had expertise that could help. And, you know, we had a little bit of time in between the other work that we were doing to pull this together. Everybody did. And I suppose it's that, I said it before, it's kind of like your 15%, what you have autonomy over, what you can do. If you really believe that it's important, stick with that and put together something. And even if it helps a few people, it's worthwhile doing. So I think that's kind of very empowering as well. And even when, you know, when I was at home, when I was self-isolating, I kept working on it at that time, because I really believed that it was really important just to do something to try and support our colleagues in the nursing homes who were working so hard and doing such a brilliant job at the time under extremely difficult circumstances.
Thank you very much, Sharon. I love your message about the 15%, and that personal dedication shines through. Thank you for sharing that with us today. Now I'm going to come to Adeline Quinn. Adeline is an SLT manager in Stewarts Care. And I'd like to maybe ask you, first of all, Adeline, I'm not sure that everybody might be aware of the services at Stewarts Care, and I think it might be useful if you kind of give us a little brief overview of that before we start.
Hi Jackie, yes, definitely. I suppose Stewarts Care is a service that's based up in Palmerstown in Dublin, and it's a voluntary organisation that supports children and adults with intellectual disabilities. So it's a lifelong service. And it has a range of services here across CHO7 as well. So there's a special school, a preschool. We also provide early intervention services, and there's also then 25 residential homes on site here in Palmerstown, independent and supported living, and 30 community homes across local communities here in around Palmerstown and Lucan. And I suppose as well as that, we would have quite a lot of day services and supported employment services here too. So I'm part of the multidisciplinary clinic, and the clinic would consist of dietetics, speech and language therapists, occupational therapy, psychology, physiotherapy, and positive behaviour support, social work and safeguarding, to name a few. So we're quite a large multidisciplinary team. And again, we're based and we work across all those services. So we provide clinical supports to children and adults here with intellectual disabilities. And I suppose kind of, you know, one of the main things in working in a disability service is that we would never work in isolation in the clinic. So we work very, very closely with the frontline staff that work in the residential and community homes and day services. So nursing and care staff are essential to us to be able to do and follow through with our clinical duties. But also, most importantly, the service user is always the centre of the service that we provide here in Stewarts Care. So families are extremely important, and again, other external agencies or teachers in SNA. So we're constantly working alongside others here in the clinic. We're part of one service in Stewarts Care.
Thank you, Adeline. So a very broad service supporting a very broad range of people there. And I'm thinking COVID must have had quite an impact on that service and how you were able to support those people. Could you tell us a little bit about the challenges that COVID posed for you in your service?
Definitely. So I suppose, like many other disability services across Ireland, we were in completely uncharted territory. So many of and most of the services that we would work within were suspended or paused or closed. So the school and the preschool day services, and also our early intervention services that would be clinic based. So they were all suspended at that time. And also, I suppose the residential and the community homes remained open. So they were open, but obviously with very stringent infection prevention control measures in place. And you know, for us as clinicians as well, and you know, this is something I suppose that we all felt at that time was, you know, when the directive came to work from home, that's exactly what we did and worked from home, but it was a completely different way of us working. So we would always be on site or in a home or in the school or in the clinic. So it was completely changed, I suppose, our traditional idea of what we did as clinicians. And And again, you know, similar to Sharon as well, we were asked to be redeployed to areas as required. So there was a range of us that were requested to do the COVID-19 swabbing, and also our administrative teams here provided contact tracing support as well. And again, just to highlight, I suppose, working in a disability service, the clinic will never exist on its own. And there were teams and departments across the service that were experiencing those challenges. So, you know, we were very fortunate to have a very strong COVID nursing response team. We have GPs on site, and we have infection prevention control as well, and frontline nursing and social care. And you know, without their support, the clinic wouldn't have been able to function as it did through that initial lockdown period. So, again, we were very fortunate to have that support system in place.
And as you reflect back, Adeline, what were some of the highs and lows from that period as you remember them?
I suppose in terms of, like, you know, the low first, you know, working in Stewarts, there's a very strong sense of community. So you're constantly working in environments that are full of activity and friendship and life, and that would hold a lot of memories, you know, both good and bad for us when we're working as clinicians. And then coming in and they were suddenly silent and closed, it was just quite an unusual working atmosphere to be in. And again, like many of our health and social care professional colleagues, you know, we did lose people to COVID-19, and that for us was very challenging as well. But I suppose, you know, one of the highs was that the positive parts of this was that we continued to get through it together as a team, and that, you know, it was the focus on the service users that grounded us. So maintaining our clinical supports to service users, and that again, I suppose, you know, did facilitate our resilience in many ways, was by having them as our focus throughout all of this, is that we were, you know, aiming to keep our clinical services open as much as we possibly could, so that they were at the centre of the service still. And I think something that we were, you know, just talking about recently here as well is that the availability of CPD. I mean, we've never had as much access to CPD opportunities as we do at the moment. I mean, there are constantly webinars and online learning. So, you know, being able to develop expertise and skills in certain areas, I mean, that's definitely been a positive as a health and social care professional, is the opportunity to do that CPD now as well.
Fantastic, and thank you for sharing those insights. It's really very interesting to get that glimpse into what things are like in your particular kind of service. Can you tell us a little bit about, so, you know, where are the services now as we're, you know, several months in? What are services like at the moment, and how have you adapted?
Yeah, so you know, our services kind of changed from the get-go in terms of being able to maintain clinical services open. And again, we're not an acute setting, so I suppose one of our key priorities for the departments working here was to upskill in PPE. That was not part of our daily working life. So, you know, upskilling our staff in PPE has, you know, allowed us to continue working within the residential and community homes, so that we can still get in and see people. So, say in particular occupational therapy or physiotherapy, when someone is discharged from hospital, they're able to get on site, don their PPE and get in, and ensure that there's, you know, the rehabilitation needs for the person are met within that environment. And also then that blending of services. So, you know, looking at remote services and telehealth. So definitely a lot of the clinical areas at the moment are providing a wide range of telehealth services. So, for example, we would do speech and language therapy assessments and part of assessments through telehealth with families or with teachers, and be able to offer and continue to offer training and specific training modules through telehealth as well. So it really has opened up a lot of possibilities for us here in Stewarts. And I think probably, you know, looking forward from a reflective viewpoint, we may not know all of the changes and the impact that they're going to have. But I suppose, you know, from an initial get-go, the, you know, people were pushed into action and did so quite quickly. And there were helplines set up for families and service users through social work, psychology, and safeguarding as well, just to make sure that we were connecting with families and service users, and that they knew we were there and available to support them if they needed. And you know, very similar to other organisations, it was that balance as well of us, you know, participating in the COVID-19 swabbing and contact tracing, and trying to balance then our clinical demands and needs in that area as well. But I would definitely feel, you know, we're very fortunate that we have heads of departments and we have a clinical director here of clinical services. So they've been a great support in getting, I suppose, us ready for what the future might look like for clinical services.
Thank you, Adeline, for sharing that update and where you're at now. And as you reflect on those challenges and difficult times and huge period of change you've been through and you've described there, what would you say is your kind of key learning or your key takeaways on a personal level from all of that?
Definitely one of the key learning things was that the ability of our health and social care professionals here on site in Stewarts to step up to that request of redeployment. And basically, I suppose they just did what was needed, and I was part of that swabbing team myself as well. And I think, on, you know, looking back, we just took the position and we followed through what was needed of us, knowing that we still wanted to maintain our clinical services as well. And I think dealing with change at a very fast rate and trying to be innovative. So looking at how we delivered clinical services, whether it be we don our PPE and we go in, or we provide telehealth, or in some situations, you know, meet in people's gardens to provide supports. So we, you know, I suppose like that, it's dealing with that change at such a fast rate, making sure you are reducing the risk of transmission, and then by maximising what we do as well. So finding other ways to do things. I think also from a relationship and a connection point of view, it's, you know, our connection with service users, their families, key workers, and how essential that is to the job that we do as health and social care professionals. And during that period, that we didn't lose sight of the service users, that we adapted our service to meet their needs as much as we possibly could. But yeah, so they were some of the learning. And again, I would hope maybe more opportunities for reflection on the changes that have happened in the future as well.
Thank you so much, Adeline, for sharing that. I think very, very interesting insights and reflections with us. Thank you so much. Now I'm delighted to come to Dr. Damian Lowery, Senior Counselling Psychologist at the Mater Hospital. And I think, Damian, you're going to talk to us a little bit more about some work that was maybe more focused around the staff side of things. So maybe you tell us a little bit about the most significant achievement from your point of view during COVID or since COVID.
Yeah, thanks, Jackie. Well, it's fair to say that from March until June, July, even, you know, daily life for our department, the psychology department, it was transformed enormously. And as a psychologist in the Mater Hospital, most of what I had been doing up to the point COVID arrived was, you know, involvement in groups, talks, workshops, individual work with patients, etc. And that all had come to an abrupt end. So we were in almost a state of suspended animation in some ways. So, and we found that to be a bit of a vacuum. But in a way, this was the catalyst to focus the mind on something different, something that perhaps was going to make a meaningful contribution to hospital life. Or indeed the wider healthcare setting itself. And it was quite apparent, and it was topical even at the time, that the psychological well-being of healthcare staff was being tested over and above the norms of regular health service delivery. And some of that was attributable to the pandemic and how much fear it was, I guess, provoking in people, etc. There was a lot of uncertainty circulating, that's for sure. So I took an existing idea that I had, which was a study really to study or evaluate the burnout amongst Mater Hospital staff, obviously where I work, and I repurposed it into a survey that was seeking to evaluate the psychological functioning of healthcare staff across a number of different hospitals, particularly during this time of COVID. So, and this was partly the point. COVID, in many ways, created the opportunity for colleagues to work together, and in this case, psychology colleagues. So when we might not otherwise have been inclined to do so, we kind of tend to work in our own little silos, as it were. And it created the conditions in a way that brought us together. It prompted us to engage with each other and ultimately collaboratively support and endeavour to study and hopefully help our healthcare colleagues in a more meaningful way going forward.
Thanks, Damian. And can you mentioned the study that you undertook? Can you tell us a little bit about why that study is important? What's important? Why is it important to do such a study?
Well, for a start, I guess the health and well-being, physical and indeed mental of staff is important, isn't it? And some would argue it's vital. You can't pour from an empty cup and all of those sayings that kind of go along with that. So, you know, and I guess just focusing on the study itself, it'll be one of the first, if not the first, study of its kind on an Irish domestic sample. There's a good bit of research on healthcare staff, typically doctors, medical personnel, and sometimes nursing staff too, and their psychological well-being. And it's generally, you know, UK populations or samples, and likewise US samples. There isn't a huge amount, if any, studies in the domestic Irish context looking at that issue. And it's also distinct from the existing literature in that we're looking to evaluate all healthcare professionals across 5 Dublin adult hospitals. Most studies, as I said, look at selected disciplines. We want to capture the psychological functioning of HSCPs, or health and social care professionals, who make up a quarter of the health service workforce, and indeed other disciplines. You know, like I feel at times they're the forgotten bunch, you know, the porters, catering staff, admin, who are Trojan workhorses in certainly the clinics that I'm party to, IT personnel, estates people who are very, very active in the matter at the moment. They're probably, you know, being pushed to the point of it being the brink, because there's a lot of transformative development and capital infrastructure going in. So these guys are like literally working around the clock, maintenance staff, etc., to kind of make these clinics kind of happen and get built. And they're often the ones on the front line of service delivery, even if they're not always the ones getting the claps on the doorsteps, you know, or the candles lit for them and all of that. They all these disciplines deserve the plaudits, you know. So I felt that was another important aspect to our study to be inclusive in that regard. And finally, I guess we're seeking to track psychological functioning of staff over time. And most studies are cross-sectional, and what that really means is they kind of take a measure of how well people are doing or not so well at a particular point in time. And we've obviously done that. So just this September gone, the study went live and we had it open for the entire month, and we've a lot of data to sift through and make sense of. But we're also going to reopen the data collection window in February and again next September. And even though not everyone who did it in September just gone will do it again in February or next September, we're hopeful that a sizable kind of cohort of individuals will do it on 2 or 3 even occasions. And that'll allow us to track people longitudinally, so over time. And in that way, it just allows us the opportunity to identify factors that actually cause or are significant contributors to some of the psychological problems that we might be seeing.
Thanks, Damian. So that's a great outline about the study. Can you tell us what you hope is going to be accomplished then by this study?
Yeah, sure. I've possibly kind of touched on it maybe already, but we do hope it'll be a seminal study. You know, that's a big kind of promise, and we hope to deliver. But that it will, you know, be a bit of a landmark study, even if there are, and I'm aware of other groups in the West and in the Southwest who are sort of looking similarly at this issue. But, you know, just by virtue of population distribution, Dublin is where 1 in 4 people on the island tend to live. And I think across the 5 sites we're capturing data from, 50%, give or take, of the COVID cases were managed on those sites. You know, so it's sort of standalone in its own respect. And we really hope to identify factors associated with negative mental health outcomes amongst healthcare workers across the 3 different study time points. And I know that tends to be the main focus, doesn't it? You know, we look to the negative, we want to see what the problems are. But I would also like to think, and I am hopeful, that we'll also focus to some extent on factors that are associated with positive mental health outcomes amongst healthcare workers. And there's a lot of talk about resilience, and it's a bit of a buzzword, and I do I am an advocate for resilience building, and it is possible. I'm not trying to, but we measured resilience using a fairly robust questionnaire, and early data suggests that it isn't in any way associated with the problem. So you'd imagine people high on resilience aren't going to be high on stress, but they actually are, you know, and vice versa. So it's an interesting point to tease out, shed further light on, because what we might talk about or what we might mean by resilience might actually look quite different to what we're trying to do about it. And I would love to, you know, make a meaningful contribution in that respect. Finally, you know, we are hopeful that we'll disseminate the findings by way of peer-reviewed journal publications, conference talks. I'm attending a conference tomorrow and Friday virtually. Hopefully, come, you know, what next year we'll be back to perhaps being in person, but also perhaps more importantly, disseminating this information on site across these hospitals, you know, because it's the executive tier of these hospitals and perhaps even further afield in the upper echelons of the HSE that need to know this information so that they can hopefully act upon it if there's enough of a rationale to do so. So that's really what I hope will come from all of this. I'm not asking for much.
Thank you very much, Damian. That's been really interesting. And thank you again to Sharon and Adeline, both of you, for sharing your insights and your journeys and the examples of particular work you've done over this time. I'm now very pleased to hand back to Mary Samuel.
To summarize, I would like to highlight the key points discussed by each of our panel members that align with leadership skills, specifically demonstrating leadership being put to practice. I'm going to start with Sharon. As I was listening to her, I was drawn towards how our own experience of the symptoms of COVID-19 placed her in a unique position to reflect on it, which then helped her to develop an empathetic response and to lead in a compassionate way. Amidst her coping with her own recovery, she found this extra capacity and had the drive to lead and contribute to this project. Adeline's sharing revealed how things changed during COVID-19. The change from busy, buzzing, full of life work environment to a silent, closed place. HSCPs working from home, all these making them to reflect on the power of working alongside and in collaboration with service users and other team members. Adeline also reflected on the loss of service users to COVID-19 and the impact it had on their staff, their service. To me, this highlighted an important characteristic we HSCPs have, the connections we make with our patients, service users, their families, and how important it is for us not to lose it. Damian's sharing in a nutshell depicts the importance of future-proofing, the importance of data, research to complement clinical work, and the need for such information to make policy changes. Though not called to be part of frontline services, the vacuum that was created by the temporary cessation of services led them to respond in a meaningful way. Reaching out to other professionals, looking at the feasibility of conducting a longitudinal study within Irish settings, and making it a reality is for sure a contribution that requires commitment and perseverance to see it through. Thank you once again, Jackie, Sharon, Damian, and Adeline. Our sincere thanks to Ms. Tina Joyce from RCSI for her expert advice, help, and support to make this webinar a reality. Our thanks to Suzanne and Miriam from RCSI operational and technical teams, respectively. Please refer to the slide for our contact details. We are looking forward to meeting you in our next webinar. Thank you.